Hi there, it's Dr. Amo Raju again on the Ambassador Talks, ready for another 30-minute stimulating conversation. This time I'm joined by Dr. Shehla Imtiaz-Umer, who is a local GP, and we'll be having a conversation around all things to do with the NHS, equality, diversity, and well, we'll see where the conversation goes. So let's get straight into it. Shehla, welcome to the Ambassador Talks. Please introduce yourself.
Hi, thank you so much for having me, Amo. I'm Shehla Imtiaz-Umer. I'm a GP in inner city Derby, born and bred from Derby. So was born and grew up in Normanton and have stayed here pretty much all my life. Work as a GP, but also really interested in how to empower our local community to be more health literate and what we can do to help particularly marginalised communities to empower them with their health.
So when you say health literacy, what do you mean by that? Let's put it in layman's terms for people like me who probably just aren't familiar with those kind of terms.
Absolutely. I think it's really important for us to all educate ourselves about our health. We know that ethnic minority groups, particularly Black Asian, South Asian communities, are more likely to have multiple medical problems. And a lot of that can be addressed through educating our communities about the health issues that are more likely to affect them, but also thinking about, the communities within which we live and why that makes us more likely to have certain health conditions. And health literacy is simple things of actually what can you do in your diet to make sure you're preventing yourself from having diabetes? What can you do to keep your fitness levels at a high enough level so that you prevent having high blood pressure? So it's educational ways of engaging with our communities to make sure that we're being as healthy as we can within our communities to help make sure we're reducing our risk of having long-term diseases and conditions that affect our ability to live healthy lives.
So that's really important. I mean, one of the things I've noted, I've been working in the community with primarily disabled people, and there's almost an expectation that when you're disabled, you're expected to have have diabetes, you're expected to have hypertension and maybe even some weakness in the heart. I don't think that's necessarily true, though. I think it's just it's a misconception that disabled people are expected to have these conditions. One of the things, frightening statistic I came across just last week in a previous conversation with on a podcast was around dementia. Dementia is on the rise in many communities, and I was told that at some stage, half the population will eventually, the end will be down to dementia. Does that worry you as a GP?
I think there absolutely is an increase of dementia, particularly in South Asian communities, and we're certainly seeing that anecdotally. The research behind that and the reasoning I'm not aware of, so I'm not going to speak to something that I don't have in-depth knowledge about. But certainly as a community, I think we're becoming more aware of dementia as a diagnosis. And we know that as we age, our brain function does deteriorate. So there is going to inevitably be some inability to function mentally as we would have done in our younger years. And that's a reflection of obviously the health service and how we've brought in so many treatments for problems that potentially many years ago there wouldn't have been. And now we're living longer, which does mean you're more predisposed to dementia just as a whole. But our community is certainly being affected more by dementia, and it's a lack of awareness in some quarters, certainly, about what that looks like. But when they do have a family member with dementia, it can be extremely difficult. And when you overlay that with coming from an ethnic minority and societal expectations of caring for people with dementia, then that becomes a more complex picture to try and manage.
Yeah, and that's I've just become a dementia champion,
right?
Trained by Alzheimer's Research UK last week, so I'm hopefully learning more to be able to pass on that and raise awareness in the community. But one of the things I'm also mindful of is the fact that there's a real thing in the community, particularly with some commissioners, and I've got personal experience of this as well. There's an expectation that the disabled people in the South Asian community have stronger care networks. I think that's incorrect, isn't it? What do you think?
I think as a community and a South Asian, a person who's been brought up in a South Asian community, I think that our family members have traditionally, through the generations, cared for our family members. And I think that family network of either direct family and extended family is absolutely something that is relied upon. Does that make it correct? And does that mean that commissioners can then shy away from providing care for those people who have got a family network? And I think that's obviously a question for them to answer. But I think that's something for us as a community to be actually proud of. You know, we do care for our unwell family members.
I think we do, Shehla, but one of the things I'm mindful of is the fact that the next generation of youngsters going through, they don't have that mindset that they're going to look after their parents the way, you know, certainly my generation had. So, and that's not anything that they're at fault, or it doesn't make them evil in any way or anything.
Not at all.
It's just that they've got the pressures of work. A lot of them actually work away from home now, and they've moved their families. You know, their husbands and wives and children have gone to different cities. So I think there's a misconception sometimes, certainly when it comes to health-related access to health support, health and care, that they're going to have a strong family network to support them. So I just want to be mindful that we've got some work to do there to educate commissioners around that, because they do have this, no matter what they say, they do have an expectation that the families are going to all pull in together.
Absolutely, and I think that possibly reflects on why the health inequalities, where there's an expectation of certain communities potentially that isn't on other communities, and you know, reflecting on the generational shift in terms of care for you know, our family members. Yes, that, you know, compared to when I was much younger and what was expected of our families, yes, you know, the pressures are very different, and the expectations and societal expectations are now very different. But if the experience from what you're hearing and what you've had yourself is that actually there's an expectation that no longer exists, then, you know, clearly that's a gap that needs to be addressed. And, you know, coming back to the dementia and the lack of awareness, I think the other aspect of lack of awareness around our community is getting involved in research. So, you know, there are active research projects, particularly around dementia research. So there's an open research study for anybody to sign up, so that we can track over the years what is happening with people in dementia diagnosis. And, you know, until our communities get involved in such initiatives, we're not going to have the data to know that what we actually need to help support that community. And I think, you know, I'm happy to provide you with a link afterwards for people to sign up to that, but I think that's a really important thing for us to highlight.
Absolutely. And one of the tasks that I've set myself as well as a dementia champion is to get the communities, everyone involved in research, because we're always, you know, as disabled people or people from minority communities or whatever group you think you belong to, we're consulted to death, we're researched to death, so there's a bit of apprehension about getting involved. So people need to understand what the benefits are of them being involved, and it's not always, you know, invasive blood tests or anything like that. Sometimes it's just talking to people, and that helps with the research. So we're going to have to, there's a bit of work you and I have got to do there.
As an aside, just while you're talking about research, I'm actually the research inclusion lead for the ICB. So really working with communities to understand, and we know what the barriers are. It's a lack of awareness, a lack of engagement because of the barriers to access to healthcare. And trust is a massive issue. And, you know, we need to try and understand what we can do to overcome those barriers. And our marginalised communities are those people from an ethnic minority background, but those people who have a physical disability, those people with a mental health diagnosis as well. So, you know, we have a lot of work to do to get those people involved in research so that we can really actually understand what we need to do to help them reach their best potential in life.
You talked about health inequalities in general, and I'm mindful of, no matter which city you live in, there's incredible health inequalities in the demographics based on geography where you live. You can live in, you know, quite affluent wards within your city, and your life expectancy is 10, 14 years better than somebody living in the inner city in the urban area. And I think, again, there's some work to be done. It's the same people. Often people go to work to the same office or the same factory, but live in different areas, and their life expectancies are different. What's your thoughts on that? What do you think we could do in terms of and trying to educate and encourage people to live in a healthier way or access healthier food in general, and opportunities to which improve their life expectancy.
I mean, this is such a fascinating topic, and that there's a whole space of research around social determinants of health. So that looks at, why is it that people living in a certain area are more likely to have health problems compared to more affluent. So, we know that if those people who have access to power and privilege, is that through their job? Is it through their level of education? Is it through to their housing status? Is it because English is their first language? What is their mental health status? And when you think about all of those different parts that make up a person, there are people who absolutely have privilege because they're in those sections that have that power concentrated in those. So if you're white, able-bodied, of robust mental health, slim body, you don't have any problem, you're neurotypical, so you don't have any neurodiversity issues, you're more likely to get through in life and succeed and accumulate wealth and power, and so on. And our communities are absolutely affected by social determinants of health. We often have multi-generational living. We often have our members of our community who are frontline facing jobs such as, manual work, whether that's, taxi driving, bus driving, working in factories. And that inevitably means that you've got very limited financial resource to be able to do the things that will allow you to live healthier lives. And that includes access to healthy foods. And we see, the absolute mushrooming of, Normanton Road as an example in the fast food outlets. But that's just one reflection of where we are, that actually, and that's because we are, our communities lack the access to healthy food options because of the pricing. Often these fast food, and this is not a criticism of our communities at all, we can only access what we can afford and get hold of. And there has to be a massive piece of work, and that comes through public health and prevention and education around what are the healthier options to make sure that we're living healthier lives. And that could be a whole podcast series in and of itself about what you can do to address that. There's so many different things that can happen.
One of the things I've been it really kind of frustrates me is, the expectancy, and this can be repeated in any cities, not just Derby where we live, but you go to any city, there's an area where the high street is jam-packed with fast food takeaways and sweet shops, and that's the chances are, and I'll put money on it, the chances are that's where the health problems are at the highest as well in the city. Whereas, at some stage, those applications will be going into planning committees. The planning committees needs to have a conversation with themselves as well to say, what are we doing to that area by allowing more takeaways and sweet shops in that area? We're almost encouraging people to live that way, where people enough, you try and get 10 takeaways in a row in Alistair. It just won't happen.
It won't happen.
But it's very convenient to put it on Normanton Road in the city, and then the same practitioners will be scratching their head saying, "How come everybody in this area's got hypertension and diabetes?" You're kind of part of the problem if you're allowing that to happen. So I think there's some work to do, not just to the community, but with the community, but also with those decision makers, the policy makers who are allowing this to happen. But yeah, I mean, so what kind of work are you specifically involved in at the moment with the community?
Well, I do a number of different roles. So I'm involved with a charity called Evergreen, which is really a charity helping women and young women to be empowered. So we look at spiritual, physical, mental well-being, provide initiatives for them to really become involved and actually have that ability to be socially mobile. What are we doing to provide those opportunities for them to be holistically having their needs met, so they can be productive members of society? And that's really enriching and fulfilling, just seeing, that we recognise that, women in Normanton, for example, whether they're Pakistani Muslim, are not having the opportunities that other communities are being offered. So that's been great. I also, I'm an advocate for British Islamic Medical Association, so I lead the advocacy team for that organisation. And that was really on the back of what had happened during COVID. And the British Islamic Medical Association wasn't something I'd historically been very involved with. But in COVID, we noticed that Muslim communities, particularly at the intersection of South Asian communities, Bangladeshi, Pakistani, were not taking up the vaccine, as an example. We had higher mortality and morbidity rates, so higher, chances of getting infected and very unwell with it, and then also dying. And there was a lot of work to be done with our community to engage with, actually, have you got COVID? This is what you need to do. And that was a massive turning point in recognising, I think, within the NHS and society about the effect of health inequalities. And we have to recognise the impact of, faith, ethnicity, gender, and all of these interplaying factors that mean that we're more likely to become unwell, we're more likely to die compared to other communities. And that's moved on to other ways of how we can advocate for our communities in terms of health. So doing lifesavers, which is teaching our community how to do basic life support, education around cancer screening. So it's an organisation that does a lot of community work, but also helps Muslim healthcare professionals. And one of the things that just springs to mind is the Islamophobic riots of last summer.
Yeah.
And that really affected our communities and, the asylum seeker population that I work with as a GP, but also as a Muslim healthcare professional and as a Muslim as a whole, that whole rhetoric was very disturbing. So, we're trying to help put support in for our colleagues, but also our patients. And then alongside that, I also work in equality, diversity and inclusion as a GP, looking at discrimination in the workforce and actually how discrimination in our workforce impacts patient outcomes. We know that if you're, being discriminated in as part of your job, you're going to have an adverse outcome on patients. So that will translate into a further widening of health inequalities. And, those are a varied number of roles that I do, but it enriches my day job, which is essentially being a GP. That is who I am at my core. And it's something that
Where do you find the time to do all this and be a GP?
I don't.
Gosh, that's some. You've got a big job description there.
Yeah.
I mean, it's all needed.
Yeah.
Everything you've said, I thought, gosh, that is needed.
Yeah.
And you're also writing prescriptions as well. Yes. Gosh, wow. Okay.
And writing a book. So.
Wow.
Yeah, and
welcome. I'd love to. I love talking to people who've written a book.
I edited the book, with my colleague who's Dr. Frayne. He was my GP clinical tutor when I was a medical student. But we edited a book together called The ABC of Equality, Diversity and Inclusion in Healthcare. And that's because we know that if you are from a marginalised community, you're more likely to have a less favourable outcome.
Yeah.
And that book really covered the whole range of topics, including ethnicity, social determinants of health, being a woman in healthcare, but importantly around actually people with physical disabilities, what is their experience of healthcare? And I think that's really important at the moment, particularly when we're looking at what the government's bringing in last week around the PIP applications and the assisted suicide, and actually how is that going to affect people from those communities that, for those people who have disabilities.
Yeah, I mean, you've talked about disabled people and the NHS and access to health. There is a big conversation, a continuous conversation going on amongst disabled people's organisations and even disability influencers across the UK about the lack of trust between disabled people and the NHS. And a lot of that, as you touched on, came to light particularly around the pandemic. Mm-hmm. I was involved in a piece of research to look at the experience of disabled people from minority communities during the COVID pandemic. And one thing that came out strongly was that the massive levels of mistrust and apprehension, and just poor experience after poor experience being listed by so many, and alarmingly, so many disabled people had a "do not resuscitate" added to their medical file without them even being told. It was just applied to them, and I think this subject, this topic of "do not resuscitate," isn't discussed enough in the community, because at some stage most of the population will have it applied to them if they get seriously ill, and we need to have an open and frank conversation around what it means and what people's rights and choices are, because there is this thing, certainly within the South Asian community, where if you work in the medical profession, you're almost considered a god. When God says to you, your loved one's not very well, we're not going to resuscitate them, or we don't advise that they be resuscitated, you kind of accept, okay, well, you know best, you've got the years of medical training, I don't know these things. But again, the experience of disabled people is that those medical professionals don't always know best, and they need to be challenged. They're humans just like you and I at the end of the day. And I had my own example was my dad had a heart attack, and at the end of his bed in A&E, the doctor was talking about putting "do not resuscitate" right in front of him, and he could hear everything. That doesn't help the patient who's thinking, am I going to die now? And I had to fight for that conversation to be taken outside. I said, let's go and talk outside. And then on top of that, I had to fight again once he was moved to the ward, because they wanted to apply it to him then again. It's a constant fight for disabled people to stay alive when they want to stay alive. So, we're talking about assisted dying bill at the moment. That's another conversation, which we could probably have a conversation on another podcast on.
Yeah.
But from the NHS's perspective, what's your thoughts on this, and what disabled people should and shouldn't do in terms of their rights and choices on, when that question is put to them?
I think what you've touched upon is clearly an emotive topic. When we have a loved one who's very unwell, and they're approaching the end of life, how do you have those conversations? And having been in that situation as a doctor, and also as a family member who had a very young relative have a "do not attempt resuscitation" order, I've certainly felt it from both aspects. And firstly, I'm sorry to hear about the experience with your dad, and it sounds like it was challenging. And could there have been things from what you've described that could have been done differently? Yes. I think that there is a lack of understanding, actually. What does DNAR actually mean? And the perception, certainly from conversations I've had, has been that, well, a "do not resuscitate" order basically means that we're not going to do anything to help this patient, and that's not what that is. So a "do not attempt resuscitation" is usually used for those cases where the patient is so unwell that if their heart was to stop, or if they were to stop breathing, that their chances of resuscitation are minimal to negligible to pretty much impossible. Like that, resuscitation attempts are physically very difficult because you are pushing on the chest wall with a high degree of force, and it's not uncommon to end up with rib fractures. And actually, you've gone through the distress of that and putting that patient through that distress of, pumping and pushing on their chest, and actually you've not had the outcome that you think. And we have to balance out our desire for a quality of life versus having comfort at the end of life, versus prolonging life, even though you've got no quality of life. And, those are difficult conversations to have at the best of times. But when you're in that situation where you've got a very unwell relative, then there has to be some open dialogue about that. But even prior to that, there is space for us to think about that. And, in the last decade or so, we have a respect form now, which really allows conversations for those people who we recognise as having long-term conditions, are likely to deteriorate. Then what are their wishes? Do they want to prolong their life? Is it that actually they want to stay comfortable at the end of their life, and they want, medical professionals to keep them pain-free, for example? Where do they want to die? Where do they want to be cared for? So having those conversations early is really important. But in situations of extremis where somebody's come in very unwell, those are challenging conversations, but I think we also need to understand that it doesn't mean that we're withdrawing antibiotics or, blood thinners or anything like that. It just means that in those two circumstances, if you deteriorate and your heart stops or, you stop breathing, that's very simplistic layman's terms that I'm putting this in, then, and that is a clinical decision. But, being aware of or, having those conversations with relatives in advance and saying, well, actually, if this happens to me, this is what I don't want and this is what I do want. And I do think, there have to be those conversations, particularly in our community. We probably don't have them enough.
We don't. And there's so many people particularly with the first language isn't English.
Yes.
When they don't fully understand and they don't understand their rights. But as you were talking there, what was going through my mind is it still should be, the final decision should still be with the individual. If they are fully compos mentis and they know what's going on, the final decision needs to be with that individual as to whether they want to stay alive, whether they want people to do everything they can to keep them alive.
Yeah.
What I don't want is a scenario where family members and the medical profession are making that decision in front of that individual whose opinion has not been taken into consideration.
Yeah, and certainly as part of that, decision-making process, there is, a question on that. Has this been discussed with the patient? So, it really does depend very much so on the situation that you're in. And the ideal situation would be to sit with our patient and say, actually, this is how unwell you are. And this, this is what we're going to try and do to help support you. But there is a chance that you may not. And if your heart stops and, you stop breathing, then we won't be able to resuscitate you. I completely accept that there is an optimal way of doing it. And I'm sorry that wasn't your experience. But, ultimately, a do not resuscitate order is, I put in inverted commas, it is a medical decision based on a whole range of factors. And ideally, we want the family to be part of that conversation as well as the patient. And, there are a number of factors which means that it doesn't happen that way. And hopefully that will be addressed through patient awareness of what that means. But also, thinking about the conditions of which that situation has arisen in.
Yeah, and I think it's all very important, those issues that you've just mentioned there. I think for me, just to give you a short example, I went on a radio call-in show and a number of phone calls came in from the public when they were talking about the assisted dying bill. And what came across very strongly from those conversations on the phone were that it wasn't really up to the disabled person. It seemed to be a lot of carers were saying, I can't see my loved one go through this. And then the final call on that particular day when I had this conversation was a disabled woman herself says, the presenter actually asked, why do you think it's okay? Why are you for assisted dying? And she said, well, I don't want to be a burden on my family. Again, that's the wrong reason.
Exactly.
And that a lot of disabled people feel that
Absolutely.
the family and the medical profession, they're just a burden on, financial burden on the medical profession and an emotional and physical burden on the family. So probably better that I go. And that's what worries me about, DNRs and assisted dying, which you and I will probably have a conversation on another future podcast about. But you'll be surprised to know we've come up to the end of our 30 minutes.
Oh, wow. That's flown by.
What's one of the final things you want to say? What kind of message do you want to get to the public about health and health inequalities and some of the work that you're doing?
I think it's the key message that I want to give is that find out what's going on in your community. There are so many different initiatives that are carried out, whether that's British Islamic Medical Association for the Muslim community, what is the Indian community doing, the Sikh organisations, the Hindu organisations. There are so many things that we're trying to do to offer our patients the best way, best opportunity to make the best out of their lives and prolong healthy lives, and look out for those opportunities. But also don't be afraid to use your voice and advocate for yourselves. I think, as you were saying, whilst you were talking, in the South Asian community, doctors are seen as gods. And, I think we have, as a society, moved away from that. But I think, we should empower ourselves to know about our conditions and be able to speak to, you know, healthcare professionals about what we're going through, because nobody knows their health condition better than the person experiencing
Absolutely.
it. And as a doctor consulting with patients on a, you know, almost daily basis, you would know your condition better than I would. And yes, I know what it means in a textbook. Do I know what it's like to live as that person? No, I don't. And, you know, use your voice, advocate for yourselves, and be part of that kind of two-way conversation to make sure you understand what the medical perspective is and we take on board what your perspective is, so that we can work together to be healthier and happier in our lives.
Thank you so much. That was Dr. Shehla Imtiaz-Umer, a local GP who's shared some thoughts and insights around health inequalities. And we've covered a lot today. And I think we probably need podcast number 2 on with Shehla, just to kind of cover some more topics, because health inequalities and the NHS and such a massive subject. We can't squeeze it into 30 minutes. Thanks once again for tuning in. I'll see you next time on the Ambassador Talks. Stay well.